EKG Chapter 9, Introducing the Junctional Rhythms. Congratulations if you made it through that last video. This one will be a little easier to get through. Let's see what we're going to talk about. We're talking about the origin of junctional rhythms. You know we got to talk about the components of the electrical conduction system. We're going to talk about PJCs. We're also going to talk about a junctional escape rhythm, and then accelerated junctional tach, and then just the clinical significance. So when we talk about junctional rhythms, the origin of it. So junctional rhythms are classified based on their origin in the AV junction, which is located between the atria and the ventricles. So when the SA node and the atria fail to generate an impulse in the AV junction, it takes over as the heart's pacemaker. So junctional rhythms are those that begin in the AV junction, like I mentioned. While they're generally not considered life-threatening, it's important to remember that patient assessment is the key to determining the clinical significance of these rhythms. Now, normally the electrical impulse originates in the SA node, travels through the atria via the internodal pathways. This is the usual pathway that ensures that the heart beats in a coordinated rhythm. However, in the case of junctional rhythms, this normal pathway is disrupted. Now, after the electrical impulse reaches the AV node, typically a brief pause allows the atria to finish contracting before the impulse continues down to the bundle of His. From there, it travels through the right and left bundle branches, ensuring that the ventricles contract in a synchronized manner. Now, in junctional rhythms, this pathway still functions, but the impulse originates from the AV junction instead of the SA node. And then after traveling down the bundle branches, the impulse moves into the Purkinje fibers, which spread throughout the ventricular musculature. This ensures that the ventricles contract effectively, and that allows for proper blood flow throughout the body. So even in junctional rhythms, the impulse continues through this pathway, but it's coming from the AV junction rather than the typical SA node. Now, when the SA node fails to generate an impulse, the AV junction can step in and take over as the pacemaker. So with this secondary pacemaker, the atria will still contract first, just like normal, but the ventricles will follow with a delay since the impulse is originating from the AV junction rather than the usual SA node. So in junctional rhythms, the impulse can travel retrograde, meaning that it can move backwards. Instead of the usual progression from the atria to the ventricles, the conduction can flow from the AV node or ventricles back through the atria. Now, this backward flow of electrical activity is what causes some of those unique characteristics that we'll talk about of junctional rhythms. Nothing new here, you've seen this, but the SA node talking about our firing rates and how impulses transfer and all of that stuff. And then we know we've got our pacemaker sites and their rates, their intrinsic rates. All right, so let's talk about some differences, some of the things that we're gonna see, those characteristics of junctional rhythms. So in a normal rhythm, we typically see a P wave before each QRS complex. Remember, that represents the atrial contraction. However, in junctional rhythms, the impulse is traveling in the opposite direction, away from the positive electrode. So because of this, the P wave may appear inverted or negative on the EKG, since the electrical activity is moving backwards through the atria. So in junctional rhythms, the P wave can either be hidden within the QRS complex. It can even actually appear after the QRS. And this happens because the impulse is coming from the AV junction, which may cause the atria to depolarize either before or after the ventricles. So the QRS complex itself is typically narrow, since the ventricles are still being depolarized through the normal conduction pathway, just like in a regular rhythm. Now, PJC. So we're talking about junctional rhythms. Let's talk about PJC. So all junctional rhythms, when we're talking about junctional rhythms, they're initiated from a single site in the AV junction, or sometimes the bundle of His or the Purkinje system. They arise earlier than the next expected complex of their underlying rhythm. So when an ectopic depolarizes the SA node, it causes a non-compensatory pause, which interrupts the normal rhythm of the heart. So this pause happens because the SA node has not had time to reset before the next beat. So that non-compensatory pause occurs, meaning that underlying rhythm is interrupted without a compensatory return to the expected timing. So we're still talking about some PJCs. They can also cause a compensatory pause. So this pause occurs after the ectopic beat, but it doesn't disrupt the underlying rhythm. So in other words, the heart skips a beat, but the rhythm picks back up exactly where it left off, maintaining the regular pacing of the heart. And then as a compensatory pause, the way it's kind of categorized by, it's a pause that occurs after the ectopic beat. And then, as I said, that underlying rhythm remains uninterrupted, meaning the timing of the subsequent beats aligns with the original rhythm after the pause. So this occurs because that ectopic beat did not reset the SA node, allowing the heart to resume its normal pacing immediately afterward. So PJCs, we see what is the rate. We see the rate of the underlying rhythm. Remember, when we talked about premature beats with atrial, said you've got to determine the underlying rhythm. So say it was a sinus rhythm and it had a PJC, it would be sinus rhythm with a PJC, not just a PJC. Rhythm is usually regular, of course, except for that premature beat. And then the main difference we see, because of where it's being paced from, is within that P wave. We notice that it's inverted or absent. So that's because what's being initiated after the SA node. So it's having to go retrograde. Let's take a look at what something like that looks like. So in this particular one, when we look at this, we see 1, 2, 3. Now we notice that doesn't fall in line with these guys. We'll notice that when we look at the rhythm. But 1, 2, 3, 4, 5, 6, 7, 8. And we've got rhythm looks a little off right here. That's unexpected because we do not see a P wave here. We see P waves with these other ones. Oops, except this guy. So we see a hidden P wave. Remember, it can be either hidden or inverted. It actually can be back here also after the QRS. So this would be a sinus rhythm with a PJC. Actually PJCs, because we see the second one down here as well. So PJCs, they're less common than PACs or PAVCs, but they can still occur. So just like with other ectopic beats, it's easier to identify PJCs and the rhythm is either sinus or Brady. When you're interpreting PJCs, it's important to also determine the underlying rhythm, as I was talking about, because the premature beats might look different depending on what's happening in the rest of the heart's electrical activity. All right, now junctional escape rhythms. So these things occur when the SA node fails to generate an impulse, or if the SA node's rate falls below that of the AV node. Then the AV node will take over as the heart's pacemaker. So this is just the safety mechanism of these pacemakers to ensure that the heart continues to beat. So the intrinsic rate of the AV node is between 40 and 60. So when it takes over, the heart rate will fall within this range. So a junctional escape beat, that occurs when a single, rather than just the whole rhythm that we saw, the single isolated junctional beat takes place. Usually when the SA node has temporarily failed to fire. On the other hand, a junctional escape rhythm happens when a series of these junctional beats occur, which can sometimes be referred to as junctional Brady if the rate drops below 40. So this rhythm is the heart's way of keeping a steady beat when that SA node isn't working as it should. Now some causes of that can be caused by several factors. We see SA node disease, so the SA node isn't functioning properly, or some other things like hypoxia because of that lack of oxygen to the heart. Of course, increased parasympathetic tone, so vagal tone, it slows the heart. And then certain cardiac drugs and of course complete heart block, where those electrical signals between the atria and ventricles are blocked, that forces the AV node to take over. So what is the rate? Usually 40 to 60, that's going to be our rate. And then the other main difference is when there's a P wave, it's inverted or absent. Everything else is the same. So, and you could see a shorter PR interval too. So when we look at this though, we see 1, 2, 3, 4, 5. So we're at 50. Whenever we look at our rhythm, it looks quite regular. Let's go here. So 1, 2, 3, 4, 5, 6. Just about on our strong line here. 1, 2, 3, 4, 5, 6. So we're pretty regular. P waves, we see that they're inverted. So that tells us it's being paced in a different place. By knowing what we know, that an inverted P wave tells us it's a junctional rhythm. So a junctional escape rhythm or a junctional rhythm, because the rate is 50. Now let's talk about accelerated junctional rhythm. So accelerated junctional rhythm, that occurs when there's an increase in the automaticity in the AV junction. So it causing it to discharge impulses at a faster rate than its normal intrinsic rate of 40 to 60. So that heart rate in this rhythm typically falls between 60 to 100. We're talking about accelerated, so 60 to 100. Causes of that accelerated junctional rhythm include hypoxia, digitalis toxicity, inferior wall MI, and then rheumatic fever. Now all these things irritate the AV junction and cause it to fire faster than usual. So the only real difference that we see on this one is we look at our rate, 60 to 100, which we know is different than what we were looking at before with our junctional escape rhythm or junctional rhythm, which was 40 to 60. So now we're at 60 to 100, still at the P wave being inverted or absent, and then our PR interval is usually less than 0.12, just because of where it's being paced again. So let's take a look at this. We've got 1, 2, 3, 4, 5, 6, 7. A heart rate of 70. Looks pretty regular. 1, 2, 3, almost 4 boxes. And then 1, 2, 3, 4, 1, 2, 3, 4, 1, 2, 3, 4, about 4 boxes. So rhythm is regular. P wave, we don't see a P wave, no P wave within this. So no PR interval, and then our QRS is within normal limits. So because the heart rate's 70, we've got an accelerated junctional rhythm. Now junctional tach. Junctional tach, it's a rhythm that originates from the AV junctional tissue at a rate of 100 to 180. Now if this rhythm starts or ends suddenly, it's called paroxysmal junctional tach. Sometimes you might see it as PJT, referred to as that, and sometimes be difficult to distinguish from SVT. That's because as it gets squished together, and SVT, you're not going to see a P wave, as well as here, you're not going to see a P wave. So they both share similar characteristics. Heart rate, often an abrupt onset or termination as well. Talking about junctional tach. So it can be caused by several factors as well. Underlying ischemic heart disease can be a problem. Frequent ingestion of stimulants, anxiety, hypoxia, medications like digitalis, rheumatic heart disease. Treatment's just primarily focused on identifying and addressing the underlying causes of that. So we're kind of looking for that root issue, help manage and potentially resolve the rhythm disturbance that we're looking at. So once again, only thing changing is going to be our heart rate. Look at it a little bit faster. So when we look at this guy, we see 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So we got a rate of about 100. Rhythm looks quite regular. 1, 2, and a few. 1, 2, and a couple. So rhythm is regular. Now the P wave on this one, we see it down here. So it's after the QRS, which we know it can be inverted, absent, or after the QRS. So of course there's no PR interval. The QRS is nice and tight. So by the standards that we know, that would be junctional tach. Now let's talk about some clinical significances. So when we talk about these junctional rhythms, let's talk about PJCs first. Now all this depends on how often they occur and the patient's overall condition. So isolated PJCs, typically minimal significance, meaning they aren't usually a cause for concern on their own. However, when PJCs occur frequently, meaning more than 6 a minute, there's an increased risk that for more serious dysrhythmias could develop. So in these cases, management generally involves just some close observation. That's about it. Now we'll talk about some more rhythms. So junctional escape rhythm, is assessed based on the patient's heart rate and clinical conditions. So we know that intrinsic rate of the AV junction, typically 40 to 60. It's important to watch for signs of compromise, such as decreased perfusion, just because of their heart rate getting slower. That could indicate the heart is not pumping effectively. So, if signs of compromised perfusion are present, treatment may include O2, and drug therapy could be considered, help increase that rate or stabilize the rhythm. So usually, a heart rate of 50 to 60s can be well tolerated in most patients, but as well, it all just depends upon that patient's status. Now, accelerated, generally well tolerated by most patients. However, sometimes can indicate digitalis toxicity, especially if the patient is on medication, like digoxin, obviously. It's important to carefully monitor the patient for the potential development of more serious dysrhythmias. So while this rhythm may not be immediately life-threatening, its presence should prompt attention to ensure it doesn't progress or signal a more critical issue. So junctional tach can be well tolerated in patients with healthy hearts, but it can be a problem in those with cardiac compromise. So patients may report feeling that their heart is running away or fluttering, which is a sign that rhythm is affecting their comfort, possibly their circulation. So treatment for junctional tach depends on the patient's clinical appearance and then the signs and symptoms, of course, that they present with. So it's important to assess how the rhythm's impacting their overall condition to determine the appropriate cause of action. So let's take a look at a couple. So we got our rate, 1, 2, 3, 4, 5, 6, 7. Heart rate is 70. Looks quite regular. 1, 2, 3, almost 4 big boxes. 1, 2, 3, almost 4 big boxes. So it looks like we're pretty regular. Now let's look at our P wave. We do have a P wave, however, it's inverted. You see that's inverted. PR interval, we do notice it's probably a little bit short. As we mentioned, that could be a shortened PR interval. So by our standards, this would be accelerated junctional. And then as we look here, we see 1, 2, 3, 4, 5, 6, 7. Although when we're looking here and we're just walking across, we notice this seemed to come early, as well as this little guy here looks a little wacky. So we got a rate of what do we say, 3, 6, 7. So we've got a P wave here. Rhythm looks pretty regular, other than whenever we get into a little wacky-do stuff here. So P wave looks pretty regular there. Now this P wave is inverted. So we've got an upright P wave, inverted P wave, upright, inverted. So it looks like we have bigeminy of whatever we have every other beat. So these are inverted P waves. So I'd say that we have sinus rhythm with PJCs. When we look at that, so I promised you guys it would be a little less than the last one. So go ahead and work on the rest of these in your book, and we'll see you soon.